دكتور عمرو زكي، دكتور ضياء المنشاوي، اتفضل دكتور عمرو، دكتورة إيمان. يا بنداري فين البرزنتيشن فين بتاع الدكتور بنداري؟
خلاص
احنا في عرض الدقيقتين يعني. اوكي.
Okay, thank you, Professor Ashraf, for this introduction. Today, within the upcoming few minutes, we are going to shed the light on one of the innovative drugs for treating patients with chronic coronary syndrome, and this is ranolazine. And we are trying to provide the clinicians, all of us included, a simple user manual of this drug. First, we should know that despite the fact that coronary heart disease was highest in the old century in the Western countries, today we are on the burden in the MENA region, and this MENA region, of course, including Egypt. And the data for Egypt is not to that extent good. If we look to the WHO data that have been released in 2018, we will find that coronary artery disease was responsible for more than 160,000 deaths, representing more than 29% of the total deaths, putting Egypt in the 15th rank worldwide. And I do think that this is alarming. Ischemic heart disease has long been divided into two major categories. Those patients with acute coronary syndrome, which are not the scope of the presentation today, and those patients with a stable coronary artery disease who have been renamed in the recent guidelines as chronic coronary syndrome. Some patients are with obstructive coronary artery disease, and this is the most important category, but we should not forget those patients with ischemia and no obstructive coronary artery disease, otherwise named INUCA, and this gives due credit to the microcirculation. The guidelines also teach us when to start with CT coronary angiography, or even non-invasive assessment. You can start with CT coronary angiography if the pre-tested probability is low and the clinical characteristics of the patients are permissible. But at the same time, you can go directly for invasive coronary angiography if the pre-tested probability is high and the patient is having high level of angina at very low level of exertion, or if the patient is starting from time zero with LV systolic dysfunction. We also have been taught in the guidelines that we have three pillars of treatment. Number one is the lifestyle. And this should be emphasized more than that. Lifestyle do actually works. Number two is the medical therapy. Number three is the revascularization. The point I'd like to highlight here is that revascularization does not always resolve the whole problem of patients with chronic coronary syndrome. And we do have data. If we look to the seminal randomized control trials evaluating medical therapy versus PCI in patients with chronic coronary syndrome, starting from the ARTS trial, going through the COURAGE, the SYNTAX, the FAME, the BARI2D, and even recently the NHLBI registry, we will find that 1 year after revascularization, almost 25% of patients come again with chest pain. This means that 1 in every 4 patients after 1 year mostly will become symptomatic again, despite complete revascularization in this well-controlled clinical trials. And recently came the ischemia trial, which randomized more than 5,000 patients with moderate to severe ischemia between receiving invasive strategy in addition to optimal medical therapy or optimal medical therapy alone. And stable coronary artery disease did not benefit in terms of hard outcomes from initial revascularization strategy. And a few weeks ago, we know the data from the extended phase of the ischemia trial in the recent AHA sessions 2022. Those patients were followed up for an additional 2 years, so we now have an almost 5.7 years of follow-up. There was not even a shred of benefit in terms of all-cause mortality in those patients. So please, forget about the clogged pipe theory in patients with a stable coronary artery disease. This theory actually works in patients who are still symptomatic, but it doesn't usually solve the whole problem. Now let's move to look to the guidelines and see where is the ranolazine from the guidelines. The most important change in the recent chronic coronary syndrome guidelines is that we learned that there is no distinction between those patients with acute coronary syndrome and those patients with chronic coronary syndrome. Every day that passes after the patient experiences an acute event, he or she gradually moves from the acute stage to the chronic stage. So it's more or less like shades of black to white, not black and white. And this has been stated in the guideline. The guidelines tell us that up till now, we have no universal definition on what's optimal medical therapy, and that each patient should have his or her dress. The medical therapy should be tailored according to the clinical characteristics, the hemodynamic profiles, and even, and sit down for this, the patient preference. This should be part of the equation. The guidelines also tell us that we have 6 different clinical profiles for patients with chronic coronary syndrome. The first profile are those patients with coronary artery disease who have stable symptoms, and the second category are those patients who have LV dysfunction and discovered to have coronary artery disease as an etiology. The third category are those patients who are asymptomatic, but they discovered coronary artery disease accidentally during screening. We also have those patients who are less than 1 year after ACS or PCI, those patients who are more than 1 year after ACS or PCI, and always, we should not forget those patients with vasospastic or microvascular angina. But I'd like also to highlight and stress on the fact of double products. And this is one of the major determinants of myocardial oxygen consumption. And we have been taught in the medical school that double product equals heart rate multiplied by systolic blood pressure. And this explains why the drugs acting directly on the double product will remain the mainstay of therapy in patients with chronic coronary syndrome. I mean here specifically beta blockers and calcium channel blockers. But let's take a synopsis about the mechanism of action of ranolazine or Ranexa. Ranolazine simply is a selective late sodium channel inhibitor. And this could lead to reduction in the intracellular volume sodium overload. This also could lead subsequently to reduction in the intracellular calcium. This could lead to reduction in the diastolic tension, improvement in the contractile properties, reduction in the risk of serious arrhythmias, and finally, better handling of ATP at the tissue level. This is what the guidelines say. This table speaks about the different ischemic drugs that could be used in patients with chronic coronary syndrome, again and again. The first line therapy in those patients should remain beta blockers and or calcium channel blockers. You can use them in combination. If the patient is still symptomatic, you have to use one of those medications, nicorandil, ranolazine, ivabradine, trimetazidine. But I'd like to stop here and stress some important facts. The fact number 1, all these drugs are given the same level of recommendation and power of evidence. The fact number 2 is that when the drug came to the market late, this does not necessarily mean that the drug should be used late. And I'd like here to refer to the story of sacubitril valsartan and SGLT2 in heart failure. They came to the market within the last 2 to 3 years. And now we are speaking about what we call the 4 pillars for treatment of heart failure with reduced ejection fraction. This is similar to this actor. For our foreigner guests, this is Mahmoud al-Maligi, one of the most famous Egyptian actors. He used to act evil roles in our films. But in reality, he was a very kind person. And we also remember his kind role of the farmer in El Ard, which was directed by Yusuf Shaheen. Please, forget about the predetermined assumptions about drugs. When the drug came to the market late, this doesn't mean that it should be put late in the hierarchy of treatment of any condition. I'd like to take the bar higher and tell you that even beta blockers and calcium channel blocker strategy first in patients with chronic coronary syndrome is not supported by well-conducted randomized controlled trials testing this strategy against For example, if you started with nicorandil, ranolazine, trimetazidine, the evidence here is dubious and is weak, arbitrary actually. The guidelines also tell us again that we have different profiles. Those patients with high heart rate, those patients with low blood pressure, those patients with low heart rate, those patients with LV systolic dysfunction. You can't start all medications in all patients. You are not a robot. For example, you can't start beta blockers in patients with true bronchospastic lung disease. You can't start calcium channel blockers in patients with low heart rate. You can't start beta blockers in patients with coronary artery disease and decompensated heart failure. But this figure speaks it all. We can divide them into 4 major categories. The first category are those patients with adequate blood pressure and high heart rate, those patients with low blood pressure and high heart rate, those patients with adequate blood pressure, low heart rate, and those patients with low and low. Ranolazine can be used being a metabolic agent in any category, and it is the only, and I'll say it again, the only medication that can be used together with trimetazidine in those patients who have low heart rate and low blood pressure. The NICE guidelines also give due credit to ranolazine. The ranolazine is given FDA approval to be used in patients with chronic coronary syndrome. The American guidelines also give ranolazine class 2A indications. This is one of the few drugs that's approved across the Atlantic. And now let's look to some real-life cases to see how could we employ or prescribe ranolazine in those patients. First case is Mr. Osman, who is 51 years old male smoker with typical angina 3 months ago. His blood pressure is 90/60 and heart rate is 62 beats per minute and regular. His echo showing diastolic dysfunction grade 1. He has a positive stress test. He is very annoyed from nitrates headache and asking for an alternative. This patient is not candidate for beta blockers and calcium channel blockers. Look to the heart rate and to the blood pressure. Of course, you cannot prescribe nicorandil in this patient because nicorandil induces headache and the patient is already annoyed from headache. The only drugs we have as an alternative is ranolazine and maybe trimetazidine. Yes, we have evidence from the MARISA trial, which was a randomized double-blind trial, testing the efficacy, the dose-response efficacy of ranolazine as a sole medication in patients with chronic coronary syndrome who are symptomatic for more than 3 months. And this drug resulted in a significant improvement in all exercise test parameters, the exercise duration, the duration to angina, the duration to 1 millimeter ST sigma depression compared to placebo. And the relation was linear, consistent, and graded. The second case is Mrs. Hanan. She is a little bit old, 69 years old, hypertensive and dyslipidemic. She had PCI to LAD 1 year ago with normal other coronaries. She is coming with recurrent chest pain, but the LAD stent was patent in a recent coronary angiography. She is on bisoprolol 5 milligrams. She uses occasional sublingual nitrates. Her blood pressure is 120/70. Her heart rate is 66. She is asking for optimization of medical treatment. Here, you cannot augment the dose of beta blockers because of the heart rate. Also, because of the heart rate, the calcium channel blocker is not an option. You can give this patient long-acting nitrates on chronic basis, such as nitroglycerin capsules. You can also go to trimetazidine. You can also go to ranolazine. You can also go to nicorandil. But I might be a little bit afraid to prescribe nicorandil in this patient. This patient is mostly on double antiplatelets, and nicorandil has been associated rarely in some population with incident GIT ulceration, and this could be problematic in this patient, but it's not an absolute mistake. It's not an absolute contraindication. And we do have evidence from the CARISA trial, which is a randomized double-blind trial, testing the hypothesis of adding ranolazine as an anti-anginal medication to beta blockers, for example, in patients who are still symptomatic. And this trial was positive, improving also the angina frequency parameters in addition to the exercise test parameters. The third case is Mr. Said, and this is a very silly case. He is a 57 years old, hypertensive, diabetic. He has also documented peptic ulcer disease on BPI. He has COPD on occasional budesonide formoterol inhaler. He has recurrent external chest pain, so he was subjected to coronary angiography. The coronary angiography in 2021 revealed diffuse multi-vessel, small vessel disease, not amenable for any further revascularization. We do see these cases, yes? Yes? He's on amlodipine 10 milligrams, perindopril 5 milligrams. He uses long-acting nitrates, trimetazidine, but stopped the ivabradine due to some ocular flashes. Blood pressure is 130/80. His heart rate baseline 80 beats per minute. He's asking for options. Actually, beta blockers might not be the best option. It's actually a wrong option here because of the bronchospastic lung disease. Calcium channel blockers also could be an option. Yes, I may shift the amlodipine to verapamil. It's a dihydropyridine calcium channel blocker acting better on the heart rate, but those are calcium channel blockers and these are calcium channel blockers. It might not work. Of course, if the patient already is on trimetazidine, on nitrates, I'm afraid of prescription of nicorandil because of the potentially rare risk of GIT ulceration. I may go for ranolazine for this patient. And we do have data from the ERICA study. The ERICA study tested Mr. Saeed. The ERICA study tested the hypothesis of adding ranolazine in addition to optimal medical therapy, including amlodipine, in patients who are still symptomatic. The patients included in this trial was exceeding 560 patients. And the trial was positive, but I'd like to highlight the fact that adding ranolazine to amlodipine did not result in any significant change in any hemodynamic parameter, systolic, diastolic blood pressure, and even the heart rate. And this feels good, this feels safe, and this feels assuring. The fourth case is Mr. Omar. He is 42 years old, smoker, type 2 diabetes on insulin. He had recurrent chest pain with positive stress test, but normal epicardial coronary arteries in recent coronary angiography. This is a typical case of ischemia, ischemia with no obstructive coronary arteries, and we do also see these cases. His blood pressure at baseline is 110/70. His heart rate is 68. He had intolerance to beta blockers with self-reported erectile dysfunction. He is on verapamil 120 milligram daily, nicorandil, trimetazidine, and occasional sublingual nitrates. And he is still having bothersome symptoms, asking for help. We do see these cases. The only option for this case will not take beta blockers. He refused it, erectile dysfunction, and don't forget that the patient is diabetic. We do have data from the Teresa trial, and what I'd like to highlight about this trial is that this is the first, and I do think the only trial in the literature testing patients with type 2 diabetes and chronic coronary artery disease in a randomized fashion in the literature. Those patients are very difficult to treat patients. And this trial was significant in favor of ranolazine, but I'd like to stress on the fact that the efficacy of ranolazine in this trial was not dependent on the baseline hemoglobin A1C. So whatever the hemoglobin A1C of the patients, those patients benefited equally significantly from ranolazine. The last case is Mrs. Hanan. She is a female, 51 years old, dyslipidemic, obese. She has chronic coronary artery disease, chronic coronary syndrome since 2017. She was doing well, but she was hospitalized for non-STEMI recently in January 2022. She confirmed that she is very compliant on her medications, including bisoprolol 5 milligrams daily, amlodipine 5 milligrams daily, nicorandil, aspirin, statins, and long-acting nitrates. She is not willing to do cardiac cath. مش عاملة قسطرة. Blood pressure 120/70, baseline heart rate 67. Echo showed advanced degree of diastolic dysfunction, grade 3. She asked you, doctor, I heard about an anti-anginal medication my sister brought from Italy. This is called Ranexa. Will it benefit me? The answer may seem yes. If we looked into the Merlin-TIMI trial, despite the fact that this trial, which randomized more than 6,500 patients with non-STEMI between ranolazine and placebo, this trial was a little bit neutral trial. It didn't meet its primary endpoint. However, if you looked into the subgroup of patients who had prior coronary artery disease, and those patients represented 54% of the total population, they do benefit in terms of the exercise test parameters, angina frequency, and they did well in terms of quality of life. And one of the most important associations between ranolazine and the ECG changes is the QT prolongation. and thus the safety of ranolazine has been in question for some time. But thanks to the large population size included in the Maryland TIMI, this was the basis to contribute substantially to answer the safety issue. If you looked into the incidence of clinically significant and serious arrhythmias, there was a significantly lesser numbers of serious arrhythmias in the arm randomized to ranolazine in this trial compared to placebo. And these results was the needs or the basis to provide some assurance about the validity of this drug and safety to the regulatory authorities. This is the last slide. To summarize, I'd like to summarize by this meta-analysis, which included about 46 trials testing the different combinations of different anti-anginal medications in patients with chronic coronary syndrome. Sit down for this and calm down. The only medication that provided positive benefit in all outcomes, whatever the exercise test parameters or even the clinical outcomes, the angina frequency, was ranolazine. And importantly, no trials in this meta-analysis, again, this was a 46-trial meta-analysis, included data about the efficacy of nicorandil as a solo or add-on therapy in patients with chronic coronary syndrome. So it seems at the end of the day that ranolazine may be the winner in this meta-analysis. Thank you for listening and good.